Evaluation and management of upper gastrointestinal, upper GI bleeding, UGIB, is a potentially life-threatening condition characterized by bleeding originating from the gastrointestinal tract proximal to the ligament of Treitz. Prompt evaluation and management are essential to reduce morbidity and mortality. Below is a detailed overview. Evaluation of upper GI bleeding. 1. Clinical presentation. Symptoms: hematemesis, vomiting blood, bright red or coffee ground appearance, melena, black, tarry stools. Hematochezia, rare in UGIB, usually indicates brisk bleeding. Fatigue, dizziness or syncope, signs of significant blood loss. Abdominal pain may indicate underlying etiology, e.g. peptic ulcer. Signs: tachycardia, hypotension and orthostatic changes, hypovolemic shock, pallor or diaphoresis, stigmata of liver disease, e.g. jaundice, spider angiomas, suggestive of variceal bleeding. 2. Initial assessment, stabilization, assess airway, breathing, and circulation, ABC. Secure large bore intravenous access for fluid resuscitation. Begin initial resuscitation with isotonic crystalloids, e.g. normal saline or lactated Ringer's solution. History and physical exam. Risk factors: NSAID or anticoagulant use, alcohol abuse, prior UGI or Helicobacter pylori infection. Associated symptoms, e.g. vomiting, weight loss. Laboratory tests: complete blood count, CBC, hemoglobin, hematocrit and platelet levels, coagulation profile, INR, PT-PTT. Liver function tests, LFTs, identify liver disease or coagulopathy. Blood type and cross-match for potential transfusion. Blood urea nitrogen to creatinine ratio, elevated in UGIB. Risk stratification: use scoring systems like the Glasgow-Blatchford score, GBS, or Rockall score to predict the need for intervention and mortality risk. Hirsch 3. Diagnostic workup. Nasogastric NG tube lavage can help differentiate UGIB from lower GI bleeding, but its routine use is controversial. Esophagogastroduodenoscopy, EGD. Diagnostic and therapeutic, should be performed within 24 hours of presentation for most patients. Identifies source of bleeding, e.g. peptic ulcers, varices, Mallory-Weiss tears, malignancies. Imaging: if endoscopy is not feasible, CT angiography or tagged red blood cell scans can help localize active bleeding. Management of upper GI bleeding. 1. Initial resuscitation, airway protection, intubation in patients with massive bleeding or altered mental status to prevent aspiration. Fluid and blood resuscitation, crystalloid fluids for initial resuscitation. Blood transfusion for patients with hemoglobin 7 gram per dL or higher threshold in symptomatic or high-risk patients. Consider fresh frozen plasma or platelets for coagulopathy or thrombocytopenia. 2. Pharmacologic therapy, proton pump inhibitors, PPIs. High-dose IV PPIs, pantoprazole 80 mg bolus followed by 8 mg per hour infusion, reduces rebleeding in peptic ulcer disease. Octreotide or somatostatin analogs in variceal bleeding, reduces portal hypertension and variceal bleeding. Antibiotics for suspected variceal bleeding, prophylactic antibiotics, e.g. ceftriaxone, in patients with cirrhosis to reduce infection risk. Reversal of coagulopathy, vitamin K and or fresh frozen plasma for warfarin-induced coagulopathy. Prothrombin complex concentrates for urgent anticoagulation reversal. 3. Endoscopic therapy, timing, perform within 24 hours in most patients, sooner in high-risk cases. Techniques: peptic ulcers, injection therapy, epinephrine, thermal coagulation, or hemoclips. Esophageal varices, band ligation or sclerotherapy. Dulifoy lesion, Mallory-Weiss tear, endoscopic hemostasis with injection or coagulation. Hammer 4, interventional radiology, considered for patients with persistent bleeding despite endoscopic therapy. Transarterial embolization, TA, angiographic identification and embolization of bleeding vessels. Farber 5, surgical intervention, reserved for patients with refractory bleeding despite endoscopic and radiologic interventions. Procedures vary depending on the source of bleeding, e.g. oversuing ulcers, gastrectomy. 6. Management of variceal bleeding, acute management, octreotide infusion, endoscopic band ligation, secondary prevention, non-selective beta blockers, e.g. propranolol. Consider transjugular intrahepatic portosystemic shunt, TIPS, in refractory cases. Post-treatment care, monitor for signs of rebleeding, e.g. tachycardia, drop in hemoglobin, gradual reintroduction of oral intake once bleeding has stopped. Address underlying etiology, Test and treat for H. pylori in peptic ulcer disease. Avoid NSAIDs and anticoagulants when possible. Conclusion: the management of UG requires a systematic approach, from initial stabilization and diagnosis to targeted interventions. Early resuscitation, risk stratification, timely endoscopy, and addressing the underlying cause are critical to improving outcomes.